So I'm delighted to introduce our next speaker, Dr. Jaimie Gradus. She's professor of epidemiology at BU School of Public Health and psychiatry at BU School of Medicine. She's also director of the BU SPH Center for Trauma and Mental Health and the BU SPH doctoral program. And I heard she's associate chair of the Department of Epidemiology, in addition to running a very large research program with multiple NIH and also VA grant. And I'm delighted to have you talk today.
Thank you so much. I was a little bit scared of what you might say about me after the pickleball introduction, so I appreciate keeping my secrets. Thank you. And thank you for having me here today. Thank you to Miguel, to Kaylee and Jack for all of your work in helping us do this and look good while we're doing it. Thank you so much. So I'm going to be talking today about post-traumatic stress disorder treatment to prevent cardiovascular disease, which is an area that my work has transitioned to in more recent years. And I'll talk about some of the causal inference challenges in this line of work, and at the end a little bit about how they generalize to other psychiatric disorders more broadly. So just quickly, cardiovascular disease, as probably everybody in this room knows, is a leading cause of death and disability in the United States. And there have really been incredible strides made in understanding what predicts cardiovascular disease and developing prediction models that are used in clinical practice. But they still don't fully account for the entire burden of cardiovascular disease. And so identifying novel targets for reducing CVD is critical. Post-traumatic stress disorder is a psychiatric disorder that occurs after psychological trauma. Psychological trauma exposure is highly prevalent, and PTSD will develop in some individuals following a traumatic event, with symptoms that include re-experiencing the trauma, avoidance of trauma reminders, negative alterations in cognition and mood, and hyperarousal. Prevalence is about 6 to 8% in the general population, and PTSD has been called a systemic disorder in disguise with relevance for physical and mental health. So what's the link between PTSD and CVD? Well, there's a notable body of research that documents that PTSD is associated with CVD across populations. There's work from the Nurses' Health Study. There's work from the Department of Veterans Affairs. I have done some work on this using data from the population of Denmark. And there are plausible biological and behavioral mechanisms for this. So dysregulation of the biological stress response has implications for cardiovascular health. PTSD is associated with elevations in inflammatory markers that have been implicated in CVD onset, and PTSD is associated with poor health behaviors that may increase risk for CVD. So as a result of all of that literature showing that there is an association there, NHLBI stood up a working group to put together a report on the cardiovascular consequences of post-traumatic stress disorder, and that was published in 2018. And the report identifies critical knowledge gaps and areas for future research, one of which is, can some interventions for PTSD and CVD benefit both disorders? So let me tell you a little bit about treatment for PTSD. Across organizations that have published clinical practice guidelines for PTSD treatment, the frontline treatment for PTSD is manualized or structured psychotherapy. So this is therapy that comes, as it says, manualized with sort of a strict set of appointments and topics that clinicians should cover and pretty much stick exactly to. And so as you see here, psychotherapy, there is strong evidence for the strength of the recommendation for treatment for PTSD. And the two that I will talk about most today are cognitive processing therapy and prolonged exposure therapy. For pharmacotherapy, the evidence is less good. It is not considered a frontline treatment for PTSD, but medication is very commonly prescribed for people with PTSD, and you'll see more about that in a minute. So now I'm going to turn to talking about a specific example, which is a pending R01 of mine, looking at evidence-based treatment for PTSD and CVD risk. And the primary question of this project really is, does evidence-based PTSD treatment reduce CVD incidence over a 20-year period? And it's going to be a retrospective cohort study of prospectively collected data from the Department of Veterans Affairs registries. And it will include all VA patients who received a PTSD diagnosis from 1999 to 2019, which is about 2 million people. And at this point, you might be saying to yourself, maybe if you had an extra second to think about this, you'd say it to yourself, Jaimie, how are you going to characterize psychotherapy and PTSD symptom improvement in medical registry data, right? That is not easy to do. And I will tell you. There is an incredible data source that we're going to use for this project that a colleague of mine spent a tremendous amount of time and a tremendous amount of resources creating. So 10 years, millions of dollars. He and his team used natural language processing, over 77 million psychotherapy EHR notes to identify types of psychotherapy, and PTSD symptom self-report measurements were taken from both structured data and note text, also using natural language processing. And the result of all of that effort of creating a data source where a project like this could actually be done gets us down to about 10% of the original sample, veterans that have at least 2 PTSD symptom measurements and some characterization of psychotherapy data that can be used. So this is an incredible data source. It's very unique. It's the only way I know that you could possibly answer a question about whether PTSD treatment and improvement in PTSD symptoms actually reduce later CVD risk, but inherent challenges to causal inference still remain in this work. And they fall under the categories of confounding control, treatment strategies, and length of follow-up. And I'm going to talk about each of these next. So for confounding control, the problem is really inadequate data. Obtaining data on the time before people enter the VA is incredibly challenging. So if you have somebody entering the VA on this day, well, they would have spent some time in the military prior to that. And it turns out the ability to link data from somebody's time in the military, Department of Defense data, to Department of Veterans Affairs data began only in 2020, but the Department of Defense data is pretty sparse because most people in the military receive private care that is paid for through TRICARE, which is military insurance, and data are also lagged in terms of release when to prevent breaches related to troop movement. So it's tricky to get even military data on VA patients. Ooh, wrong way. And if we think about the time before somebody was in the military, from birth to joining the military, that would all have to be retrospective self-report. There's no way, right, we have in the United States to get that kind of data on people. And so at this point, you're probably saying to yourself, but Jaimie, for causal inference, we care about the time before people start treatment, not the time before people enter the VA, which is a very fair comment. But it turns out that is not great either, because the VA, people are screened for PTSD every 5 years after separation from military service, and then every 5 years after that, which is incredible for clinical intervention and clinical purposes, right? We're catching the people that need the PTSD treatment right away. It is not so good for obtaining confounder data because it means that people are not in the VA that long before they are able to receive PTSD treatment. So we have a problem there in terms of availability of data on confounders, and confounders likely span social factors, health, behavior, and biology. And so even if we had a way to get the data on people that are in the VA, we likely wouldn't be able to get data spanning all of these different domains. The next topic I'll talk about is treatment strategies. So unfortunately, PTSD treatments are not as effective as one might hope, as we probably all wish they were. First thing I'll talk about is therapy effectiveness. So here's a study, effectiveness and comparative effectiveness of evidence-based psychotherapies for post-traumatic stress disorder in clinical practice. This is using VA data. And I'll just walk you through for a second. So this study shows here the PCL-4, which is a self-report measure of PTSD symptoms, and a score of less than 39 would be considered PTSD recovery. And this graph shows people who receive cognitive processing therapy, any amount of it, people who receive prolonged exposure therapy, any amount of it, and you see that they start somewhere around a 61 and get to somewhere around a 54 over the course of follow-up here. So they're not getting to PTSD recovery. What if we look at people who receive what is called an adequate dose of either of these therapies, of 8 or more sessions? Well, they're only getting to about 52. So they're not getting much better, and certainly not many people are getting to full PTSD recovery during the course of these treatments. And then another unfortunate issue is that dropout from these treatments is very high. So here is a little bit of an older graph, but looking at the annual prevalence of people who receive minimally adequate evidence-based psychotherapy in the VA, and you can see we're topping out right just at 5%. And this is, again, for cognitive processing therapy in the solid line and prolonged exposure therapy in the dashed line. So many, many people are also dropping out of treatment in addition to them not being as effective as we would like in the first place. So reasons people drop out, trauma-focused therapy is very distressing. People don't want to go talk about the worst thing that ever happened to them week after week after week in these therapies. Their avoidance of talking about trauma is very common. It's a hallmark symptom of post-traumatic stress disorder. And there can be just general dissatisfaction either with your clinician or with the therapy itself. So as a result of PTSD treatments not being as effective as we would like them to be, they are hard to characterize or isolate in registry-based data. So here's one study looking at modifications to these manualized therapies in the VA, and overall 62% of clinicians reported making some modification to manualized therapy. And the reasons are that patients have complex comorbidity, like a bunch of psychiatric disorders at once. There are engagement difficulties due to life stressors, and so the therapist will modify the treatment to address that or to accommodate that. And then many, many clinicians report actually integrating treatments, taking a manualized therapy and adding other stuff in or taking some stuff out just because it best meets the patient's needs. Looking at polypharmacy, here is a meta-analysis that examined polypharmacy among VA patients with PTSD, and across the studies they included, the prevalence of polypharmacy was 48%. So 48% of people are on more than one drug for PTSD, and in fact, of the included studies, the median threshold for defining polypharmacy was 5 or more concurrent medications. So people are receiving a lot of different treatments at once. And if you are hoping to do some causal inference work to identify treatments people are receiving, it can be incredibly challenging. Final issue I'll talk about is length of follow-up. It could take 20 or more years to get from PTSD to incident CVD. And these manualized PTSD psychotherapies that I'm talking about take place only over 8 to 12 weeks, which is a very, very small time period within 20 years. Of course, pharmacotherapy could last longer. For many people, PTSD is a chronic disorder, so even when the therapy ends, they will still have it for these 20 years, potentially, until CVD develops. And even for people who recover, the prevalence of PTSD recurrence is about 25%. There are also many common comorbid disorders with post-traumatic stress disorder, and those typically develop after PTSD, including depression and substance use. And when these develop, they will completely change the treatment landscape for a patient. Patients will be offered new and different treatments, and maybe sometimes dual diagnosis treatments for PTSD and substance use, but all of these things will change as time goes on. So it's really not realistic to model, if you think about all the different treatments somebody can have and all the different changes that can happen over a 20-year period, all of these transitions. So to summarize the causal inference challenges, it's hard, if not impossible, to capture adequate data prior to PTSD treatment spanning the domains of likely confounders. Polypharmacy and modifications to manualized therapy are common in routine care, and treatments may change frequently in a study period and are often given concurrently, making them hard to characterize or isolate. And time from PTSD to CVD is long, and challenges inherent in PTSD treatment and life after PTSD diagnosis may cause a multitude of changes from what was at your original time zero. So where do we go from here? I think Magda had that question too. We have the same question. So even with this incredible data resource that I believe is the only possible way to actually answer this question, PTSD treatment research is fraught with causal inference challenges that really reflect the state of the field. This is how it goes. This is how it works. It's not, us trying not to do better. This is what we have available to us. But this is also not specific to PTSD treatment. So here are 2 papers just from the last 2 years: Burning Down the House, Reinventing Drug Discovery and Psychiatry for the Development of Targeted Therapies, and one in How Does Basic Research in Clinical Psychology Lead to More Effective Psychological Treatment for Mental Disorders. And the gist of both of these papers is that we don't really know in most cases why psychiatric treatments do or don't work. We don't even have that level of information. And so thinking about all of the things that leads to in terms of people receiving multiple treatments and changing treatments frequently all leads to a landscape where causal inference can be challenging in this area. And so I would love any discussion about the best approach for applying causal inference methods to questions like this about mental health treatment. I'd love to hear great ideas that everybody has. And I'll just, if I have 1 more minute, say anecdotally, as an editor of a couple of journals, I have seen the situation occur where somebody is doing a study on mental health treatment and attempts to apply causal inference methods and does the best that they can, and then the paper goes out to review for somebody who is an expert in causal inference and not an expert in mental health, and that person will always say, reject it, it's wrong, they don't meet all the assumptions. And so I think, it's probably still better than the cohort study where they didn't think about this at all, that they would have done if they didn't at least try to use causal inference methods. So just thinking about the ways that these methods could be applied to areas where there was less known, there was less certainty, in a way that will advance this work would be really great. Thank you.